physiologist. Just a couple of things before we get started. I would ask you all to mute yourselves, please. And if you're comfortable turning off your video, that would just help with the presentation as well. If you're comfortable with that, feel free to unmute and turn your video on if you have questions at any time. And feel free to ask questions in the chat box at any point throughout the presentation. I will leave some time at the end for questions. So feel free to either type your questions up in the chat box or feel free to unmute and ask your questions. So you can do that throughout or at the end. So if you're okay muting yourselves and turning your videos off, it would just help us with the presentation. So again, hi everybody, my name is Zahab. Very excited to be here today to share some information on anatomy. I'm a kinesiologist and exercise physiologist. I've been working in the fitness industry for over 20 years, and I remember graduating from university, having all of this knowledge and all of this understanding about anatomy and physiology, but really having a difficult time applying it to movement and really, helping it to sort of tie into what I was doing as a fitness professional. So today, I'm really happy. We're going to share a couple of things. Of course, we're going to review anatomy and actions of core, hip, and scapular stabilizers. So I figured that a lot of you are probably okay with your anatomy of a bicep or a quadricep, but the core stabilizing muscles, the hip stabilizers, the scapular stabilizers, these are the areas that are really going to give you the biggest bang for your buck. And I think these are often understood, muscles when it comes to anatomy and actions. So we're going to really just focus on the core, hip, and scapular stabilizers. Unable to cover absolutely all of those stabilizers, but I'm going to try and cover as much as I can in the time that we have. We are also going to apply it to movement. So I'm going to give you some movement examples after we cover off the anatomy, the actions, and show you some videos of some maybe some different or obscure exercises that you may not currently be using in your regime right now. And sorry about that. Let's go back to our overview. So we've got the anatomy and the actions, and we've got the exercise examples. Now throughout, I'm going to be sort of chatting about compensatory strategies. I'm going to sort of sneak in some tips along the way, some alignment cues, and we're not going to cover off palpation for all the different muscles, but on a handful of them, we're going to sort of play around with some palpatory techniques to help you sort of really feel those muscles, because I think the palpation is really key. So if you're just joining in, please mute your microphones, and I would ask you to turn your videos off if you can for now. Feel free to ask questions throughout or at the end in the chat box, or you can unmute, and I will leave some time for questions at the end. So that's what we're going to cover off today. I hope that you can walk away with some really, interesting new ideas, some tips and some really effective strategies to help you as a movement professional, as a fitness coach. And now, we are the specialists in human movement, and we are, the gold standard when it comes to coaches. And so I'm really going to, challenge you to sort of think about your programming, in a really not so much in a myopic way. So really trying to take a step back at the big picture and sort of asking things like, why are you prescribing a specific exercise? What is your outcome? And I sort of start with that. Like, what am I hoping to achieve? And sort of breaking things down from there, and really helping to use your understanding of anatomy to help you with customizing a very purposeful and specific plan for your clientele. And so really trying to break out of the box of, okay, maybe you need to work with lines of pull, vectors, and different ranges of motion to help with your client's specific needs. Maybe they don't fit into the box of needing to squat in this perfect range. Like maybe their sport or their function requires them to be outside of that range or in a different range, an atypical range. So really challenging you to be, to be open to trying, different movements, different alignments, really trying to mimic the function of their everyday lives or their patterns or their sports, their activities. And then also try to think about the patterns that you're trying to solidify. And it doesn't have to be really complex. It can be as simple as trying to, solidify a linear pattern. If you have a runner, then you're going to think about more of these sort of linear movements, unilateral linear movements. So, really sort of taking a step back at the beginning and thinking about, okay, what am I trying to achieve? How can I achieve this? And maybe it doesn't fit in with, what we've been taught in some of our courses and some of our training. And then we're also going to really touch on compensatory movement, compensation, compensatory patterns. This is really big in my practice. And I really wanted to sort of bring to light how you can sort of identify, where is compensation coming from? How can I address compensation? Because I remember, at the beginning of my fitness career, trying to, let's say, fire a glute, get someone's glutes to fire. And I remember trying to spend weeks, months trying to, the same thing, trying all the different exercises, really trying to, why is this person's glute not firing? It would just take so long to get this effect. And I realized through courses and education and understanding that if I took away the compensation ahead of time, maybe it was their lumbar spine or their hamstrings or their hip flexors, maybe something else was compensating. If I could take that out of the picture, then I could get a glute to fire or whatever muscle to fire rapidly with a greater connection. So I don't want to discount, the compensatory element. And, we're going to talk about that throughout as well. So taking a step back and sort of talking about programming, but the reason why I really wanted to focus on the stabilizers was because that is your foundation. This lovely quote that, Charles Poliquin and I think Paul Chek has shared, you can't fire a cannon from a canoe. So we cannot build a tall, robust building on a crappy foundation. So your foundation is going to be really key. And I know that this stuff is not exciting. I know that this stuff can be kind of boring, but I try and sneak it in. I sneak it into the movement preparations and I sneak it into the first couple of exercises of their plan. And, if they're not really on board, I know a lot of people just want to get to the more challenging stuff. But in my opinion, you need to earn it. That stability is really key. So let's dive into the anatomy. So we're going to start with the transverse abdominis. And so what I'm going to be doing is pulling up a photo of the anatomy, and I'm going to use my cursor to kind of, walk you through the origins and insertions. And then we're going to talk about the actions. So we'll cover off all of the core muscles, and then we'll spend a little bit of time sort of recapping the core muscles and talk about compensations and alignment tips and maybe do a little bit of palpation. And throughout, I'm going to sort of sneak in some of my tips that I've sort of acquired over my 20 plus years and working in the industry. So that's sort of the structure that we're going to follow today. So, and I'm trying to make anatomy exciting. So I'm using all these like fancy little things to make it really fun. So, because I think I might be alone in getting really excited about anatomy. So here we go, transverse abdominis. The TVA or the TA is going to have origins in the lateral third of the inguinal ligament, the inner lip of the iliac crest, the thoracolumbar fascia. So you're going to see that there. And then it also has origins on the costal cartilages of the lower 6 ribs. So we're going to see some origins through here. And it's also going to interdigitate, fuse or connect with the diaphragm. That's why the transverse is really is a really key, expiratory muscle. So it's also going to, so those are the origins. Now the insertions are going to be, we have insertions on the xiphoid and insertions on the pubis in the front here. Now the transverse is going to fuse into this aponeurosis, okay, like a sheath. And it's going to fuse and insert into the linea alba. Now this sheath, this aponeurosis, is going to form the rectus sheath. So it's all going to kind of blend one into the other. Now, what's really interesting is the upper 3/4 of the transverse abdominis are going to form the back of the rectus sheath, and the lower quarter of the transverse abdominis is going to fuse and form the front of the rectus sheath. So it's probably why we can palpate the lower fibers of the transverse a little easier than the upper fibers of the transverse. But those upper 3/4 are going to form the back of the rectus sheath, and the lower quarter is going to form the front of the rectus sheath. Now, take a look at this photo. I think a lot of us, and certainly I was at the beginning of my career, really focused on these lower portions of the transverse. I was focused on cueing and connecting and firing and focusing on, approximating the hip bones and trying to get all this sort of, fired up. But I quickly realized that, holy cow, look at all of this above the umbilicus that we could be neglecting. So especially if someone is in a rib flare, a flared rib position, especially if someone is doming in through the midline of the abdomen when they're doing sort of curl ups or abdominal exercises, if they're having a difficult time managing that intra-abdominal pressure, these upper and middle fibers of the transverse abdominis are going to be really key at helping to support the abdominal wall. Now let's take a look at the actions of the transverse abdominis. So supporting the abdominal wall, of course, is going to be one, it's stabilizing role. It's an expiratory muscle, so it's going to fire on exhale. And that is why I use breath with exercise to help with connecting with this muscle. So if someone's having a difficult time, I will get them to do a stronger forced exhale to try and get a little bit of that connection, because it's an expiratory muscle. It also will assist in raising intra-abdominal pressure. And then what's really key, I think a lot of us think of the transverse as a pelvic stabilizer or a stabilizer of the lumbar spine, but by virtue of its attachments up here, it's going to be a stabilizer of the thoracic spine as well. So thoracic spine and lumbar spine and lumbopelvic stability. So what's also interesting to note is that the transverse abdominis is an anticipatory muscle. Okay, so its anticipatory role has to be reinforced in order to help with stability. So prior to moving your upper limbs and lower limbs, the transverse is actually going to fire and contract to protect and perform a stabilizing role. So prior to moving your upper limbs, the transverse is going to contract 30 milliseconds, okay, before the upper limbs are actually going to move, and 110 milliseconds before the lower limbs move. So this anticipatory effect is really key to help with providing that stability, so we don't end up with excess movement in through the spine and pelvis while we're moving our limbs. So transverse is an anticipatory, an expiratory, a stabilizing muscle that's really key. A lot of our power originates from, and stability originates from this area. So that's why I put it first. It's a really important key muscle. Anyone with low back pain, this is an area that we should be looking at. Anyone with a diastasis, this is an area that we should be looking at. If you utilize manual muscle testing, in your toolbox, testing the strength and the connectivity of these muscles is going to be key. So let's spend a moment trying to connect with the transverse abdominis. So we're going to take your fingers, these two fingers, and find your hip bones in the front. So I'm just going to unplug my headphones. Sorry, I tried to use my Bluetooth headphone, but it just sort of conked out on me. So I'm going to stand up so you can see me. So you're going to find the hip bones, the ASISs. You're going to come in 2 inches and down an inch. So find those hip bones in the front, come in 1 inch, 2 inches, and down 1 inch. So you can do this standing, you can do this seated, you can do this lying down. It's actually quite easy to do lying down because you'll be able to easily palpate. So once you've got those fingers pressing into, right on the inside of the hip bones, in and down, push down, let's just start with exhaling. So let's make a shushing sound. So you're going to go shh, or I find the shushing and the hissing really help to bring up the transverse. So you should be feeling the transverse coming up to meet your fingers. Remember, it's deep, so it's going to come up to meet your fingers. If you're feeling some connection from the top down, you could be bearing down or gripping with the rectus abdominis or the obliques. So think about a really slow sort of exhale, building and making that little forced shushing sound or hissing sound. You can also think about approximating the 2 sides of the hip bones. So thinking about closing the hip bones. Now remember, the fibers run in this direction. So we want to think about contracting those muscles in that direction. It's not a bicep. It's not going to go this way. It's very challenging because we're contracting it in this plane. It's a little more challenging. So hopefully that gave you some insight, a little more insight on the TVA or the TA. And yeah, so let's move on to the internal oblique. So I'm really excited to cover all of these core muscles. So the internal oblique is going to have origins on the lateral half of the inguinal ligament and the inner, the middle portion of the iliac crest. And then it's also going to have origins on the thoracolumbar fascia. Now it's going to assert on the lower 3 or 4 ribs. So it could be rib 9, 10, 11, 12, or just rib 10, 11, 12, but that's on the inferior border. So it depends. And then it's going to have insertions on the pubis. It's not really clear in this photo. And then again, it's going to fuse with the external oblique together. They're going to sort of fuse through the aponeurosis, which is that sheath, and form the rectus sheath. So, there aren't a lot of tendinous attachments through the abdominal wall. It's going to be more sort of sheaths through aponeuroses. And then the internal obliques, as with the external obliques, are also going to insert into that linea alba, which is that line where the 2 rectus abdominis muscles connect in the middle. And this guy, this linea alba is really key, because if we've got some loss in tensile strength through the linea alba, then we lose the ability to transfer rotational power. So ensuring that there's really good tension, tense integrity in through this whole area is really key. And one way that we can do that is by working the internal obliques, external obliques, working the transverse abdominis. So let's cover off the action. So your right internal oblique is going to rotate you to the right. So your right internal oblique rotates you to the same side. It is also going to laterally flex your spine. So your right internal oblique is going to tip you like a teapot over to the right-hand side. And with the external oblique, we're going to get some compression and work in when you're exhaling forcefully. So those are the actions of internal oblique. And there are a lot of similarities with external oblique as well. So the external oblique is going to originate on the external surface and the inferior border of the lower 8 ribs. And then we're going to have insertions on, so there's also insertions on the pubis, which is tricky to see here, also on the iliac crest. Now, again, it's going to fuse with the internal oblique and that aponeurosis and help to form the rectus sheath. So the external oblique, if you can see the fiber orientation, they sort of run like pockets. So if you kind of have your hands in pockets, the external obliques run that way, and the internal obliques, so pockets, external and internal, are going to run in the opposite directions. So its role is also going to laterally flex you to the spine, just like the internal obliques. Now, what's different is the right external oblique is going to rotate you to the left. So the right internal rotates you to the right, but the right external rotates you to the left. So it's a contralateral rotator. And then when they work together bilaterally, we're going to get spinal flexion. We're going to get, again, that compression, and then that expiratory roll as well. So that's the external oblique. Now, I'm a huge fan of doing core exercises in a seated or standing position. I mean, I do think there's obviously value in doing core exercises in supine and prone on the floor. It's supportive, there's a lot of value. But if we're working with people who are spending most of their time in upright positions, I love the ability. I think it makes a lot of sense from a functional standpoint to be able to challenge these muscles in standing positions and seated positions. So in this exercise here, I just call this a standing wall press. I'm really focused on optimal alignment, especially with the ribs and the hips all lined up. I'm pushing into the wall. So I'm not doing like a push up into the wall. I'm actually pushing the wall sort of away from me. That's going to get a little bit of the serratus anterior turned on as well. I have a little knee bend. You're more than welcome to try this. I'm going to show the video, but I'd love for you to try this as well. And my feet are really close together. So essentially what I'm going to be doing in this exercise is marching. So lifting a leg, lowering, and switching sides. So I'm going to march, press into the wall, but keep my hips absolutely still. So I'm using these core muscles to stabilize the pelvis. Okay, so let's see if this works here. So a little march, pushing into the wall, and keeping the hips and lumbar spine as still as possible. So just alternating marches. So feel free to try that. We have many variations of this exercise. Sometimes we do it with a stability ball pushing into the wall. Sometimes we do it with a ball overhead. Sometimes I use a little Coregeous ball. Sometimes I do it seated, but we're just alternating sides, keeping the hips still. So using the core stabilizers to stabilize the whole lumbopelvic area while I'm moving the lower limbs. So again, we're getting that anticipatory effect, stabilizing effect, and I will incorporate the exhale, the breath, to be able to assist in the connection and the robustness of that activation. And what else did I want to say about the transverse? Okay, I think that's it. Oh, I also wanted to mention with the obliques. So the obliques are going to have an anti-rotation sort of aspect and role. So if you think about when someone is in a push-up or a plank position, those muscles, the internal, external obliques, are going to work together to prevent sort of rotation, movement in through the thoracic spine. So they're kind of also like your anti-rotation muscles. They're going to help with stabilizing the ribs, in those prone positions. Multifidus does not get enough love. And, every opportunity I get, I always try and talk about this muscle. And, in my practice today, I just finished with my last client at 5 o'clock. And this is someone who had 3 disc herniations. And in my assessment, I use a combination of manual muscle testing and movement screens. And I always use bird dog as a screen. And I palpate multifidus during bird dog to feel what's happening. And, this particular client didn't have any multifidus connection in the lumbar or sacral portions. And so let me just pull up the picture here so we can look at this beauty while I talk about it. So I'm not sure if you guys are familiar with Dr. Kathy Dooley. She's an incredible anatomist. I'm an incredible instructor of anatomy. She's based out of the US. She's in Colorado now. She was in New York. She's also a chiropractor. She has dissected I'm not sure if you guys remember if you've ever been in, I've done any cadaver labs. She has dissected thousands of cadavers, thousands. And in her practice, she has found that every single cadaver she has dissected that had a history of some sort of lumbar dysfunction. So they're able to view the history of all these cadavers. So whether it was a disc herniation, discectomy, laminectomy, whether it was, low back pain, even whatever it was, 100% of the time, she found fatty deposits surrounding the multifidi, which is indicative of an inhibited muscle. So fatty deposits surrounding that muscle would be an indication that that muscle was not firing properly, not firing. So when someone comes in with low back pain, and especially when we're looking at, multiple like disc dysfunctions, I'm always going to be very concerned about what is happening, especially down here in the sacral and lumbar portions of multifidus, making sure we can get a connection. So origins of this muscle, group of muscles, really, it's going to be on the sacrum and on the PSIS, the posterior superior iliac spine. Now, what's really interesting in the multifidus is in the lumbar vertebrae, the origins are going to be on the mammillary processes of the lumbar vertebrae. Now, once we get up to the thoracic vertebrae, the insert origins are going to be on the transverse processes. And then once we get up to the cervical ones, C4 to C7, it's going to be on the articular processes of the vertebrae. So the insertions, so those are the origins. Now the insertions are going to be on the spinous processes of the segment 2 to 4 areas above its insertion. So L5 multifidus could potentially insert on L3, L2, or L1, depending. And it's going to vary wildly from person to person. That's why we see differences in texts even with the exact origins and insertions. It's very unique and differing. It's not exact from person to person. So what's really important about the multifidus is that it is going to provide segmental stability. So think about these really short, these really short little attachments and sections of the multifidus. It's going to be really important at segmentally stabilizing the spine. So segmentally stabilizing very specific portions of the spine. So in my practice, if someone's coming in with, a back disorder or dysfunction, I'm really going to be focused more, because I tend to see, in my experience, more weaknesses or inhibitions in the lumbar and sacral portions. So that's the multifidus. It's beautiful. So together, both sides, this is just showing you the left side, both sides are going to extend the spine. One side at a time, you're going to get lateral flexion. So just like the internal external oblique, so it's going to laterally flex the spine, and contralateral rotation. So your left multifidi are going to rotate you to the right, similar to the external oblique that we talked about earlier. Now, what's really key with this muscle is it's going to provide that stiffness, that segmental stability, so stabilizing different, small segments of the spine, and it's going to provide support to the spinal column. So now I'm going to show you how to palpate it, because I think it's really important for people to feel this muscle. And, as coaches, if you're comfortable and if that's in your wheelhouse, see if you can find it on your clients. And if you're not able to find it, then we start to use cues, alignment cues. Lining up the spine is really key. If someone's head is forward, their lumbar multifidus is not going to fire. As soon as we bring the head back, boom, greater connection through the lumbar multifidi. Breath, sometimes we use the exhale to help with That core, adding in some extra anterior core stabilization can help with getting your multifidus to fire, like stabilizing the pelvis, and trying to work through different ranges. So maybe you can't feel it during just a core stabilization, but maybe it's going to work a little more in spinal extension, or maybe it's going to work a little more in lateral flexion. So play around with different movements to see, what can get it to fire. So I'm going to stand up so I can show you exactly where I want you to find this muscle. So you're going to go on your back. Now, this is your spine. These are the meaty lumbar erectors, right? Erector spinae group. In between the spine and the erectors, there's a little divot, there's a little hole. So you're going to dig your fingers. You're going to dig your fingers into that hole. So you have the spine, the erectors right next to the spine, like right next to the spine. You're going to dig your fingers. Use these fingers. Don't use your thumbs. You have greater sensation through the pads of your fingertips. So dig into, on either side of your spine, and then try. Okay, let's try lateral flexion. Did you feel it? Not the spinal erectors, but it's going to come on deep in your fingertips. Try contralateral rotation. So if you're rotating to the right, do you feel that left multifidus turn on? It should just kind of like pop up under your fingers. Try just doing like an exhale and a core stabilizing exercise, like trying to create a little bit of core stability. See if that turns it on. Maybe you're going to do a little bit of extension of the spine. So I find it really works best if you're lying on your back, digging your fingers right next to the spine, like right on either side, and then pushing one leg down into the floor. So getting a little bit of extension. It's a little bit easier to feel, in a supine position. But hopefully you're kind of playing around with that as we speak. So that's multifidus. Doesn't get enough love. I love to talk about it. Okay, so bird dog. I remember we provide videos for all of our clients, and for some reason the video that I had sent wasn't working. I said, no problem. I'll go onto YouTube and I'll look for a video on YouTube. Like there's everything on YouTube. And I think I went through 10 pages of YouTube videos, bird dog exercises, not being able to find one that was really, one that showed really good spinal stability, no arching in the low back, no cranking of the neck, no shrugging of the shoulders. So we're really, really interested in, Jamie and Scott Livingston use this core cylinder, trunk cylinder sort of analogy. So really trying to, hold a really solid cylinder from which you can move off of. And so in this variation of a bird dog, I'm loading up by using a band. So I've got a band around my foot, and I'm just securing it with my hand, and I'm just extending the leg. So just sort of reaching out, keeping my foot on the floor. This is just one variation. Other variations, I might lift the leg completely. But here I'm really focused on maintaining the stability in through the whole spine. So watching that there isn't like a dip or an arch in the low back, keeping the cervical spine well aligned, the shoulders down, grounding through the hands, keeping the knees under the hips. So that's just one variation. So sometimes I actually get people to place a dowel across the back, see if they can hold that, or try this, or place like a tennis ball, a tune-up ball, a lacrosse ball right on the low back, and see if they can keep that ball still while they're going through their bird dog variations. And then I would just put my fingers on either side of the spine, like right in there, to feel, and through all the lumbar sections. So I kind of go up and down into the sacrum as well, to see if I can get a better connection. And if we don't, okay, sometimes I'll say more core, exhale, flex the foot so the whole posterior chain is on. Another trick to get multifidus on is to engage the lats. Now, the lats attach onto the thoracolumbar fascia, and that's going to sort of connect into the multifidus, on this end through fascia. So sometimes just turning the lats on by thinking of like plugging the shoulders down can really help. So that is, I think that's all I wanted to say about that. So now we are going to move on to the quadratus lumborum, QL. I feel like QL gets blamed for a lot of things, but really, I don't know. So QL is going to have origins on the iliac crest here. And then what you can't see is there's also going to be origins on the iliolumbar ligament. And then the assertion is going to be on the inferior border of the 12th rib, and then on the transverse processes of L1 to L4. Now, QL is a very interesting muscle. It's quadratus lumborum, so it's like a square kind of shaped muscle, lumborum for the low back. So I love how this just makes it easy for us to understand what it does. So unilaterally, like one side at a time, it's going to hike the hip and it's going to laterally flex. So I'm going to stand up to show you what that means. So the hip hike is this, hip hiking. So my right QL is going to hike my hip up. The right QL is also going to laterally flex my spine. So if you poke your fingers right under the 12th rib, sort of right down there, you should feel some QL activation with your lateral flexion or with your hip hiking. And sometimes, so I'm not sure if that sound was clear, but you should feel some of the QL engaging if you're palpating right under the 12th rib. So it's easy to find the rib, right? Find your landmarks and then try that hip hike or try the lateral flexion. And sometimes I have them do both at the same time just to get, I think a lot of times where, the QL is blamed at being tight. But oftentimes in my practice, when we're utilizing manual muscle testing, it's weak. One side is tight and the other side is weak. So I'm often stretching or releasing one side and then activating the other side. So when they work together bilaterally, they're also going to extend the spine. And then of course, it's going to provide stiffness and stability to the lumbar spine. So that's the QL. Okay, I hope I haven't lost you. I hope you're still with me. Anatomy is exciting. Okay, so now just to sort of, recap on the core stabilizers. So compensations that you may see, the lumbar erectors, the erector spinae group. So sometimes we see the low back kicking on, the hip flexors, the neck flexors and extensors as compensation areas. So if you think about, how many times have you given someone like an abdominal crunching exercise? So a crunch. A crunch is spinal flexion. Now your rectus abdominis is responsible for flexing the spine. So you're giving someone a crunch and your client maybe says, oh, I feel my low back, or I feel my neck, or I feel my hip flexor. And you're like, well, that's strange. You're doing spinal flexion. It could just why isn't just your rectus abdominis turning on? But who knows why these compensations arise? And I get asked these all the time. I don't know. I can speculate, maybe it's, an accident that you had, or surgical intervention that you had, or, excuse me, holding your baby, funny for 3 years. Or maybe it's your work. Like maybe it's the way you're positioned at work. Maybe it's your day-to-day things. We just know that these things arise. I can speculate, but I don't know exactly why. But I do know that we often see the low back compensating for the core, the hip flexors, the neck flexors or extensors, especially if someone's in forward head posture, they're going to be using their neck extensors. Excuse me. Excuse me. And then breath holding. So this is something that I really would love movement professionals to pay attention to. Breathing mechanics, optimal breathing mechanics, and breath holding as a compensation strategy. So now breath holding can be a really great strategy if you're Olympic lifting, 300 pounds, whatever. If you need to lift something very heavy, breath holding can be a good strategy to help you. But for everyday tasks like picking up a pencil, using this, downward pressure, using breath holding just increases intra-abdominal pressure, maybe puts a little bit too much strain on the diaphragm. And, when we're looking later on, at people who suffer from like herniations, whether it's umbilical or inguinal or disc or pelvic organ prolapse. Breathing is something we're going to look at. How you're managing your intra-abdominal pressure is going to be really important. So, watching for breath holding and cueing breathing with movement. So inhale or exhale, try both. Whatever works, but as long as you're breathing with the movement, unless you're someone who really needs to use breath holding, like an Olympic lifter, perhaps. So now we played around with how to connect with your transverse. So I'm going to get you to palpate again. Put your fingers in that little section. So ASISs go in 2 inches, down an inch. Put your fingers in there. Now do your little shush. Shh. So find your transverse. Now bring your ribs forward, like jet your ribs out, flare your ribs. See if you can make your transverse abdominis fire. Go ahead. Shh. Were you able to connect it? Shh. Now bring your ribs back over your pelvis. Shh. It's probably easier to connect your transverse abdominis when your ribs are stacked over your hips. So try it again. Palpate, bring your ribs out of alignment. So flare your ribs. We call this a bell rung up posture or a rib flare. You'll find that it is very challenging to engage those muscles if you're not perfectly stacked. So diaphragm needs to be stacked directly over pelvic floor in order for the transverse abdominis muscles in between to optimally fire. So alignment is key. Get the ribs stacked over the hips, whether that's supine, seated, standing. That rib hip alignment is going to be really key to help with firing of the transverse abdominis. And then working with the breath, as we talked about. So whether you're using an exhale to help with the connection, and maybe you're using like a stronger exhale, using that shushing or hissing sound, and potentially maybe, if you're comfortable working with the pelvic floor. The pelvic floor musculature and transverse are co-contractors. So they contract together and relax together. So on inhale, you're going to have the transverse and pelvic floor relax. Pelvic floor is going to drop. And on exhale, the pelvic floor is going to lift and the transverse is going to contract like a piston. It's down and up, down and up. So thinking about how you can add in all these external cues to help with optimizing the muscle connection. Okay. And then we talked about using the tips of the fingers and finding your landmarks like the ASISs, or finding those bony attachments to help you. So that's the core. Now we're going to move on to the glutes. Okay, so starting with glute max, we have origins on the ilium. So we've got, they just call this is just like the gluteal line here. And then we're going to have origins on the sacrum, the coccyx. And what you can't see here, we have the aponeurosis of the sacrospinous ligament. There's also the sacrotuberous ligament, which also has an origin. And then there's going to be an origin on the fascia of the glute med. So the glute med has also an aponeurosis, so a sheath surrounding it where the glute max is going to originate from. And then, so the upper fibers of glute max are going to fuse and insert onto the IT band, and the lower fibers of glute max are going to insert onto the gluteal tuberosity. So that's glute max. Glute max is your primary hip extensor. Now there's also a stabilizing role with glute max, but from a prime mover perspective, it's going to be a hip extensor. Now the glute med is also going to originate on the ilium, and it's also going to have origins on its own sort of aponeurosis. And then it's going to insert onto the greater trochanter of the femur. And so the glute med is, I didn't quite talk too much about the glute med, but it's going to have very similar attachments on the ilium and greater trochanter. Glute min and glute max are going to have, glute min and glute med are going to have very similar sort of, I'm just going to move these pictures a little bit here just so I can see. So glute max is your primary hip extensor. It's also going to assist in external rotation of the hip and hip abduction. So hip extension is really primarily what we're looking at. And watch for lumbar extension. Okay, so oftentimes I wish I had put a video, now that I'm thinking about it, of lumbar extension. So we really want to watch that the back isn't arching when you're doing hip extension. Here's where the core sort of ties in. We want to think about stabilizing the core to help with preventing lumbar extension and really try and bring out the hip extension. So, you know, runners and walkers and like sprinters, these are all athletes that need, you know, good hip extension. Now, your glute med is going to be a really, so as a prime mover, it's a hip abductor. So it is going to abduct the hip. So let me just show you. Max. So glute max is hip extension. Okay, you may not be able to see too much, but hip extension. So hip extension, not lumbar extension. So watch for this lumbar extension, and then glute med is going to abduct the hip. So hip abduction for glute med. Now, what's really key for the glute med is it's an important frontal plane stabilizer. So what we mean by that, when you are walking or running, if you notice the hip dropping, that's called Trendelenburg's. When it drops, we're losing some of that stability in through the frontal plane. Now, oftentimes our clients come to us and they say, my glute med was weak, I was given clamshells. Okay, so I have nothing against clamshells. I think they can serve a purpose. But if you have a runner who's sinking in the hip, the clamshells are not really going to help. You need to get someone in that position, in a standing position, working on frontal plane stability. I don't think that the clamshells are going to have a functional crossover into a standing, loaded position. So, okay, let's also look at what else it does. So what's interesting with the glute med is the anterior fibers are going to flex and internally rotate the hip. Okay, so we're going to get flexion and internal rotation of the hip. And then the posterior fibers of glute med are going to extend and externally rotate the hip. So I think we often focus on these posterior fibers of the hip, extending and externally rotating, but you know, these anterior fibers can be really key when it comes to frontal plane stability. So, you know, maybe we don't always have to do a clamshell. Maybe it can be, so I have an example I'm going to show you later on, a video of great glute med exercise to get you out of the clamshell box. Okay, so those were the glutes. So this is an exercise that we often use for the standing glute max and med as working it as a stabilizer. So we know that the glute max is going to extend the hip, but working it as a stabilizer is a little bit different. So we call this a ready stance. So we've got back and shin angle parallel, little bend in the knee, hips back, nice hip hinge. And the weight is going to be a little more in the heel. So if you're noticing that all of the weight is on the outer edge of the foot, then ground a little bit through the big toe pad, but shifting the weight back and through the heel. Now, this is my partner, John. He's sliding, he's got a disc. He's sliding back at a 45-degree angle. Now, it's his left leg that we're working, this side. This is the one that's working on stabilizing, not the moving leg. Yeah, we're getting a little bit of extension and abduction on that moving leg, but it is the standing leg that's doing the work. So you really should feel this in the standing glute max med. If you've got the weight back in the heel, if you're feeling the knee, you've got to shift the weight back, and you're focused on very stable through the pelvis. Still, still, still. Pelvis, core, connected. So that's one example for glute max, glute med. Now here is a great example for your glute medius. Now, I would love for you to try this right now. You don't have to push into a ball. Push into the side of a couch, side of a chair. Get all nicely lined up. Okay, whatever you're pushing into, that knee is going to push this way. into the ball, into the side of a chair, into a couch, into a corner, into a wall. Abduct, push, and see if you can feel this glute med, the opposite glute med. So your standing glute med is going to be the one that's working. So the weight needs to be in the heel of the standing leg. It's this standing glute med that's working, and you're pushing the knee into the ball, into the wall. So that can be another, so you see John sort of like tapping on the glute med to show that that's the one that's working. So this is a great functional crossover from your clamshells to, someone who's doing a little more running, a little more load, something more standing. Okay, so now we're going to move on to the adductors, this beautiful group. So now all of the adductors are going to insert on the pubic bone. And all of them except for one originate on the pubic bone. And all of them except for one are going to insert on the femur. So the insertions of 4 of the adductors are on the linea aspera. And it's basically like this rough edge on the bone that serves as attachment points. So the gracilis is the only one that's not going to insert on the femur. It's actually going to insert on the upper portion of the tibia via the pes serine. So someone's coming to me with pes serine issues. I'm often going to look at the gracilis, test it, see if it's tight, strong. Now, what's interesting to note with the adductors is, so we have adductor longus and gracilis originate on the pubic symphysis. So if someone is coming to me with a pubic symphysis dysfunction, I'm going to be really careful with the range of motion, overstretching, being really careful with not wanting to sort of put additional strain in this area. Now, adductor magnus is going to have origins on the ischial tuberosity. Let me come back to that in a sec. So there's 5 adductors. They all obviously adduct the femur. So the anterior fibers of adductor magnus are also going to flex the hip, but the posterior fibers of adductor magnus are going to extend the hip. Okay, so you have adduction, then you're going to have flexion and extension. So magnus is often called the 4th hamstring because it can also extend the hip, just like a hamstring can. Now, because it has its origin on the ischial tuberosity, if someone's coming to me with like my glute ham insertion, that upper hamstring pain, like that sit bone pain, and you're like, okay, let's stretch your hamstrings, let's work your hamstrings. Maybe it's not the hamstring. Maybe it's the adductor magnus. So sometimes just stretching that guy out can be hugely beneficial too. So then we have pectineus. So your pectineus and gracilis are going to flex the hip, okay? They're the hip flexors. Pectineus up here is going to externally rotate the hip, and gracilis are going to internally rotate the hip. That's why we test those guys in those positions. We test pectineus in an externally rotated position and test gracilis in an internally rotated position. So it's always interesting to note all the additional functions of the muscles. I mean, we often think of, okay, you've got adductors, they adduct, but they also have these interesting roles. So flexion, extension, rotation, internal, external. So always interesting to see, what else is going on? What else did I want to talk about? Oh yes, okay, I've covered everything, upper hamstring, pubic symphysis. Okay, so I think I also wanted to talk about hip alignment with the QL. So if you have the QLs, if you have a hip that's like, one up, one down, which we often see. I remember I talked about the QLs, one often being tight and one being weak. Sometimes that alone can help to level off the pelvis. And so, when someone's coming to you with a functional leg length discrepancy, not a structural one, the QLs can be a really good place to start, seeing what's tight, what's weak, testing it out, trying to activate, stretch, roll, and then rechecking the alignment and, seeing if that has changed. So the iliopsoas is something I really want to talk about, because we often lump these two muscles, well, I call them two muscles, into one. We call them the iliopsoas. So they're commonly grouped together as one muscle, but they only have a shared insertion point at the femur on the lesser trochanter. So, and then you'll see that it has, the psoas has very differing origin points. So the iliacus crosses one joint, and the psoas you're going to see crosses many joints, like it could be more than 6 joints. So we often find that muscles that cross multiple joints are often weak or inhibited, and muscles that cross single joints are strong or dominant. So if we have one guy, iliacus, that only crosses one joint, but the psoas crosses many, we often see iliacus being a little more dominant and psoas being inhibited. And we often get people to like strip out your psoas and stretch your psoas and work your psoas and get your fingers in there. But in my experience, utilizing manual muscle testing and trying to, use different lines of pull to focus on these areas, it can be weak, and it can be weak often. So I think each guy is deserving of its own name and attention. And I really like to show you a photo, a visual. So look at this, look at the difference. So here we've got iliacus. They both share those attachments on the lesser trochanter of the femur. But the origins of the psoas are going to be on the transverse processes of the lumbar spine, so all of the lumbar vertebrae. And you've also got these origins on these intervertebral sort of fibrocartilages. So these cartilaginous and little tendinous structures in between the vertebra. Like there's a lot of sort of origins here. You can see all these little fibrous origins. So, by virtue of these attachment points, there's going to be a huge impact on the lumbar spine, not just the hip in terms of hip flexion, right? So let's give this guy the psoas, the mighty psoas, the attention that it deserves, its own name, its own, muscle group. So when we talk about its functions, we've got, obviously it's going to be a hip flexor, but it's also going to be a hip rotator, so an external rotator of the hip. And then it's going to also anteriorly tilt the pelvis. So if you think about this, when hip flexors are tight, you're going to shorten. Okay, so I'll just show you here. Your hip flexors are tight, they're going to flex. Okay, so this is going to put you in an anterior pelvic tilt. When you lengthen, we're going to get you more into a posterior pelvic tilt. So the hip, for a moment, sorry, the hip flexors are going to anteriorly tilt the pelvis. Now, the psoas is also going to assist in adducting an already abducted hip. So if your hip is abducted, then it can assist in adducting. So in addition to all of that, the psoas is going to help with laterally flexing the spine. Think about all of these attachment points on the lumbar spine. It's going to have, and I spelled this wrong, I'm just looking at this now, this is terrible. It's also going to have the ability to contralaterally rotate the lumbar spine. And I just realized I did not tell you in the QL. Did I tell you in the QL? The QL, I forgot to tell you one of the roles of the QL. So the QL is going to hip hike, sorry, just heading back there, hip hike, laterally flex, bilaterally, they're going to extend the spine. The fourth role of the QL is anchoring the 12th rib down during forced exhalation. So when you're exhaling forcefully, it's going to help to anchor that 12th rib down. So sorry, I forgot about that action of the QL. That's the last one. So look at all these actions of the psoas. It's not just a hip flexor. It's going to do a lot of roles. It's going to play a stabilizing role in the lumbar spine as well. So how do you work this muscle without sort of focusing too much on the iliacus? So what I like to do is get people abducted about 30 degrees and externally rotated about 45 degrees. So sometimes we'll do this in a standing position. I'm just doing this lying prone. So in order to feel the psoas, if we want to just, let's pretend we're lying down here, and you can lie down right now if we want to try a little bit of palpation. Find your ASIS, find your belly button, and halfway between those points, you're going to get your hand in there, your fingertips, maybe go around the rectus, maybe go do a little, and then push down. So you can try this seated too. Go halfway between ASIS and your umbilicus, your navel, find that halfway point, go around the rectus muscles, kind of dig in a little bit. Now, if you're seated, bring your abduct 30 degrees, externally rotate, then flex your hip. So if you're poking in there, you should be able to feel. If you don't feel it, put your other hand and push onto the thigh to get a little more force. So we should feel that psoas if you're like really in deep there. So halfway between your ASIS and your umbilicus, you're going to take your fingers, maybe go around the rectus and then dig in at that point. Flex the hip, see what you feel, see if you can help to palpate, palpate it. And if not, just in straight hip flexion, add the external rotation, get into this open position. Now to work it, I often work the psoas standing, but to challenge it from, just an easy position, easy way to find it, I'm just getting the leg in this position, externally rotated 45 degrees. So kind of in between straight up and all the way out. And then all I'm doing is just lifting the leg. So just flexing the hip from that position. And I would often have my clients palpate. So I would take this hand and palpate and get in there. So it's not too high, it's just a little lift. Take this hand, palpate, and try and feel the psoas engaging. And sometimes I bend this leg to support. So I'm trying to get a little bit of an open position to take iliacus out of it and just focus more on psoas. So that's the almighty psoas. So to recap on the hip stabilizers, so compensations that we often see, the low back, the lumbar erectors will often sort of kick in. Iliacus, the hip flexor, will sometimes kick in. And believe it or not, we often see the calves compensating for especially glute max. Now, why is that? That's strange. Well, if you think about gait mechanics, when your hip is extended in gait, your calf is also turned on. So you're in a bit of like a toe, as you prepare to toe push off. And we also often see the calves overworking for the glute max. And I know that sounds really strange, but it's very common. If someone is coming to me with plantar fasciitis, I'm always going to test their glutes and see if there's a relationship. How is that possible? Connected through fascia, right? Posterior line. Look at your anatomy trains, your fascial lines. The glutes are connected through the calf, through that posterior fascial line. So the calves are an area that we see that are, compensated. But other compensatory strategies that we see, rotating the pelvis, hip dropping or hip hiking, the anterior pelvic tilt, and the loss of an inverted T. So I'm going to explain this inverted T here for a moment. So again, from Scott and Jamie Livingston, in their reconditioning courses, they often talk about the inverted T. So an upside down T. So this essentially means the spine is the T and the straight portion of the T, and the PSISs are making a line to form the bottom part of the T. So if we're losing this line of this T, then we're gonna lose this beautiful stacked position. And so that's something that you want to look for in terms of compensatory strategies. So you want to think about lining up the ASISs, the PCISs, trying to get them in the same plane. And then the foot. So the foot is something, so it's interesting because 25% of your muscles, tendons, bones, ligaments of your body are in your feet. So, why are we neglecting that whole area, all those bones, muscles, joints? I think it's really important to focus on the intrinsic muscles of the feet, and the feet, when it comes to grounding and stabilizing, like that is our anchor point, our grounding point. And so we often want to work on, where is the weight centered in the foot? And if there's more weight on the lateral edge of the foot, especially if you have someone who's a big supinator, they're gonna feel more on the lateral side of the hip. And if you're trying to get their adductors engaged, or if you're trying to get something a little more medial or central, it's going to be hard if all of their weight is dumped to the outside. So sometimes we want to think about grounding through the big toe pad to think about this tripod: big toe pad, last toe pad, heel, tripod. So think about centrating the weight in the foot to see if that helps with connecting with the hip stabilizers. And of course, especially if you're seeing a lot of lumbar extension, increasing your core activation to help with stabilizing. So another way, what else did I want to say about the hips? Yeah, glute meads. Okay, no, that's good. We talked about, I was showing you in those core exercises, shifting the weight back in the heel, a little bit more in the heel, to help with increasing the glute recruitment, especially if you have someone who uses their quads, who's very quad dominant. And that's something else that I forgot to mention in compensations. Oftentimes we see the quads taking over too. So, sometimes just shifting the weight back a little bit can help with improving the connection and the recruitment. So something interesting to note, we're not going to do a palpation, although you can sort of go through the glute med action, the abduction, and see if you can feel that connection. But something that you also want to look at is the timing and the firing of your hip extensors. So we'll often have people positioned in a prone position, so just lying on their stomach, and get them to extend their hip. So lift a leg up off the table or floor, whatever you're doing. And if you're not comfortable palpating the glutes, just touching the hamstrings and the low back. So I have a hamstring and low back. So the firing, so the pattern that we should see. So what was the primary hip extensor that we talked about? I'm asking a question. You don't have to jump in and answer, but your glute max is your primary hip extensor. So that should be the one that turns on first. Okay. Then we have, but oftentimes we see the hamstrings and the low back kicking on, and the glutes are kind of sleepy. They're not turning on until later, but it needs to turn on first. So think about that hip extension pattern and the timing. Okay, so if there are some issues with the timing, then maybe they start off just prone, hand on the glute, okay, glute first, then extend. Glute and core, then extend. We don't want to see the hamstrings and lumbar erectors kicking on before the glutes. They are not the primary hip extensors. The glute max is. So hopefully you got some interesting tips for the hip stabilizers. Okay, I hope I'm not boring you. Stay with me. We're just got the scapular stabilizers here. So let's talk about the rotator cuff. So in terms of anatomy, the supraspinatus and infraspinatus both have origins on the scapula, and they actually have their own fossa. So they have the origin is on the supraspinatus fossa, like a little bit of a groove in order for the muscle to attach to. Same thing with the subscapularis. It has origins on the subscapularis fossa. Now they all three, supra, infra, supra and infra are going to insert onto the greater tubercle of the humerus. Now, the subscap is going to insert on the lesser tubercle of the humerus. The teres minor doesn't have its own fossa. It's going to originate on the lateral border of the scapula, but also originate on the greater tubercle of the humerus. So the primary role of the rotator cuff is stability of the shoulder joint. So it's going to stabilize the glenohumeral joint by compressing the head of the humerus in the glenoid cavity. So primarily the rotator cuff is stabilizing the shoulder. But we also have, they're also prime movers, the rotator cuff, each of the muscles is going to have a prime movement action. So the supraspinatus is responsible for the first 15 degrees of humeral abduction. So you're going to get the first little bit of abduction. Supraspinatus is responsible for that. Some texts will show a little bit more than 15 degrees, and some texts show that it helps with all of abductions, but it's supporting and stabilizing the shoulder through that range. Okay, I'm going to skip the infraspinatus for a moment. We're going to come back to it. Just hang on. The teres minor is responsible for external rotation. Okay. Now the infraspinatus is going to abduct, extend, and externally rotate. Okay, so it's going to do, think about your throwers, okay, your pitchers, your reaching back for a seat belt. Okay, so it's also going to do horizontal abduction, but basically it's doing a lot of this. Okay, now I don't know about you, but a lot of people that come to me with rotator cuff issues have had tears in infraspinatus or supraspinatus. I rarely see tears in teres minor or subscap, infra, supra. And we saw how big infraspinatus was compared to teres minor. So if we're going to be giving someone an exercise, if we're trying to build robustness, or if there's a partial tear and we want to get the strength, you know, get people ready like prehab for surgery or post-surgical intervention, if we're trying to get these muscles turned on again and stronger, why are we doing all of this when this isn't really going to help to target infraspinatus? We're going to get a little more, maybe a little bit through external rotation. But again, you know, circling back to the beginning, if we're trying to get really specific, if we're really trying to be purposeful with our programming, you know, maybe we need to get someone up in this position working through external rotation to get more of the fibers of infraspinatus to connect and contract. That's my little rant. Okay. And then subscapularis is your internal rotator, so coming inwards, but it's the strongest out of all four. It's a very powerful guy. It's often tight, at least in my experience. It's also going to help with adducting the humerus. Okay, so then let's talk about the mid and low traps. So now it's interesting, similar to the transverse abdominis. So we often lump the transverse as a whole, but I think, and maybe this is hearsay, I think at one point there was talk, or maybe when they were sort of way back, you know, determining the anatomy, you know, I think there was a point where maybe they were going to split the transverse into upper, middle, and lower fibers, just like the trapezius. And certainly, you know, because I utilize a lot of manual muscle testing in my practice just to give me some information. It works for me in addition to movement screens. And, you know, I will utilize different, I mean, I have 5 different muscle tests for transverse, and I have separate tests for the upper, middle, and lower fibers of transverse abdominis. The same thing here. You know, the traps are sort of lumped into one, but I think it's really important to, you know, to separate them and to really focus on their roles. You know, their roles is like upper trap, mid trap, and low trap, because they have distinct actions. So, so the mid traps are going to have origins on the transverse processes of C7 to T4. Now, I've seen some texts describe their origins as T1 to T5, and that could very well be too. I think it depends. Now, the low trap is going to have origins from T5 to T12. And they're also, both the mid and low traps are going to have origins on the supraspinous ligaments. Now, the mid traps are going to insert on the spine of the scapula, the acromion process, and the clavicle itself. The lower trapezius is going to insert on the medial border of the spine of the scapula. So look at the orientation of these fibers. I mean, they are just, they're very different, even though they're part of one muscle group. So the upper trapezius, its role is scapular elevation. So it is going to shrug your shoulders, okay? Scapular elevation. Now, how many of our clients are like in a shrugged, shoulder shrug position throughout their day? Like 90%, right? Everyone's up here. Now, the mid traps are responsible for scapular retraction. Okay, so they're responsible for retracting the shoulder blades, bringing the shoulder blades together at the back. The lower traps, the lower traps are responsible for scapular depression, so bringing the shoulder blades down. So I'm just going to show you. The mid traps are going to retract the shoulder blades, and the lower traps are going to depress. Okay, so mid traps are going to bring the shoulder blades together, and the lower traps are going to depress or bring the shoulder blades down. Now, the lower trapezius muscles are also going to upwardly rotate the scapula. Okay, they're involved in upward rotation. So do the upper traps. So the upper and lower traps synergistically upwardly rotate the scapulas. Now, we often have clients come in saying, I was prescribed shoulder shrugs because I have downward sloping scapulas. Okay, my shoulder blades are downward sloping. And I think the thought process is because the upper traps are well known for their elevatory and upwardly rotating aspect of the scapula, that was an exercise that was given to them because they thought, maybe that, well, I'm sure it's going to help with upward rotation of the spine because the upper traps of the scapula, the upper traps do upwardly rotate the scapula, but so do the lower traps. So when most of our clients are spending all this time up here, I'm a big fan of utilizing, working in the low traps to get that upward rotation if needed. So I love, the I's, Y's, T's, W's, L's, V's, like all of those are really great. But we're going to chat a little bit later about the alignment and the positioning of these the structures to help you with connecting with those areas. So the mid and low traps are also going to help with providing stability, scapular stability. So stability to the shoulder blades. So that's mid and low traps. So here we have an exercise. I'm focusing on a little bit of scapular depression. So lowering the shoulder blades down, a little bit of external rotation, and scapular retraction. So I'm getting mid traps, low traps, teres minor, a little bit of rotator cuff with this exercise. So I'm doing a little bit of external rotation, a little bit of retraction, and thinking about that scapular depression to get the lower traps engaged as well. Now, if I had someone who, needed to build robustness in this alignment or open, so infraspinatus, I would maybe give them something a little bit different. So I call this a wall scap raise. So still thinking about scapular depression as I raise the arms up. So thinking about pushing back a little bit isometrically into the wall to get that external rotation aspect at the shoulder. So that's one example there. So serratus anterior is another beautiful, beautiful muscle that often gets overlooked, I think. So we've got the origins on the anterior surface of the upper 8 or 9 ribs. Now, what's really key in terms of the insertion of the serratus anterior is that, and this isn't a great photo. I'm going to see if I can go back here. Can I go back? Okay. Okay, so this is the medial border of the scapula. Now, this is a posterior view, right? We're looking from the back. This is the medial border. The serratus anterior does not insert on the posterior aspect of the medial border. It's going to attach on the other side, on the anterior aspect, facing the front, not on the back side. So, you know, when we're thinking about the role of the serratus anterior, it is going to pull the medial border of the scapula forward. Sorry, I'm just trying to jump back to my serratus photo here. So, let's just get that picture up. Here we go, serratus anterior. So we've got the origins on the anterior portion of the ribs, and then the insertion on the anterior, like underneath here, the anterior border of the medial scapula. So this insertion, this is going to pull the medial border inwards, okay? It's going to pull the medial border of the scapula. These are my scaps. These are my shoulder blades. This is the medial border here. It's going to pull the medial border forward. Okay, so your serratus is an important protractor of the scapula. All right, so it's going to help with scapular protraction, like separating the shoulder blades. Protraction of the scapula. It's also going to help with scapular stability and synergistically with with the upper traps and the lower traps, upward rotation of the scapula. Now, the reason why I really emphasize the attachments on the anterior surface of the medial border, it's my timer to tell me to hurry up, of the scapula is if you have someone with winging shoulder blades, okay, they're winging their shoulder blades, the serratus anterior is going to help to reinforce and get the shoulder blades back into a more neutral position. So anytime you're dealing with winging of the shoulder blades, serratus anterior is going to be something that you are going to look at, possibly. I'll explain a little further a little bit later. Okay, so trying to make this anatomy stuff exciting. So here we have an exercise that's going to help to emphasize serratus anterior. So basically, I'm just tacking it onto a push-up. So I'm doing a push-up, and at the top, I'm adding scapular protraction. So here's the push-up, and then I'm trying to get the middle of the spine up to the ceiling. So I'm rounding through the shoulder blades and try and get as much rounding through the shoulder blades as I can. So push-up, and then rounding, but still maintaining good spinal alignment. So my hips don't lift, it's just through the shoulder blades itself, trying to get that motion. So serratus push-up or push-up plus, it has a number of different names, but you can play around with that. So to summarize, scapular stabilizers. So oftentimes we see your upper traps or levator scap dominant. So oftentimes we're cueing people, shoulders down, get this out of the way. And we often see people using cervical extension, right? As in forward head, extending the cervical spine, using the neck extensors as a compensatory strategy. So the aligning the cervical spine is going to be key, and watching for an over recruitment of the upper traps or levator scap, watching for scapular elevation. So especially when we're talking about scapular retraction, neutral alignment of the humerus and scapula are key. So let's just practice scapular retraction, okay? Think about squeezing your shoulder blades together, basically. Try and squeeze your shoulder blades together when your shoulders are internally rotated. Okay, so if my shoulders are internally rotated, it's really difficult to get that scapular retraction. So trying to get a neutral GH joint and scap position, shoulders down, shoulders neutral, is going to be really helpful. You also want to watch that the ribs aren't flaring out. You know, oftentimes people retract their scapulas but flare their ribs at the same time. Can they maintain that rib hip alignment? So remember we talked about the scapulas, the attachment of the serratus anterior on the anterior section of the medial border of the scapula, and how that's going to help with reinforcing and helping with a winged scapula. Now, if the scapula are winging tipped this way, if they're not tipped this way, if they're tipped this way, it could be that the pec minor is dominant and it's pulling the scapula and tipping it anteriorly because of its attachment points. So if you're seeing a winged scapula this way, yes, serratus anterior, definitely. If you're seeing the winging happening this way, then you want to focus on releasing and stretching pec minor or both. So some palpatory tips and cues. Think about going through the motion. Okay, think about going through the motion while you're palpating to see if you can help with feeling the muscle. And I'm really a big fan of, feeling for the muscles while you're going through the movement to help with, okay, is there a connection? So we talked about this compensation quite a bit. What do you do? What do you do if you see this compensation? Here's a 3-step approach that you can try. Number one, identify the compensatory strategy, identify the pattern. Roll or stretch or both the overworking area. Let's say you see the calves overworking for the glutes, or you see the lumbar erectors overworking for the core. Roll and stretch the overworking area to downregulate that area. And then start with a low load activation of the underworking area. So if you're trying to get the glutes to fire, a loaded RDL may not be your best bet. Maybe you need to start with just some basic bridges just to wake the area up, to get the signaling, the patterning, the firing there. Then you integrate and load it up. So think about stretching and rolling the overworking area, a low load activation of the underworking area, and then move towards your integration. So these can all be put, number 1 and 2, into your movement preparation or your warm-ups. So this system isn't mine. Neurokinetic therapy uses this system. Reconditioning uses this system. A number of other people use this. It might be slightly different from system to system, but it's not new. And for me, it has been a game changer for trying to connect with muscles that I've been having a very difficult time getting clients to connect with. So this seems to work really well for me, and hopefully it's something that would work well for you. I really want us to, to become really proficient at, muscle connection. So in summary, we want to think about purposeful programming and using our understanding of the anatomy to drive that programming. So understanding, based on those attachment points, how is this going to help with, being very specific with what I want to achieve, and trying to think of, patterns and why. Why are we prescribing a specific exercise? And does this fall into aligning with the outcome that we want to obtain and achieve? And then thinking about really customizing vectors and lines and function to cater to movement. So, let's say we're working like a posterior delt action. We can really sort of tip things, 15, 30 degrees one way or the other to target more anterior, posterior fibers of the muscle itself. So especially like today, someone came in and their medial calf had absolutely no tone, but their lateral calf was like, how the calf has like, it was just one side was on, it was like nothing. And certainly there was some nerve damage. But, we would definitely work on changing the position of the foot and tibia to help with being very specific with what we're trying to achieve, so that we can really help to target, doing a little more turned in to target more of the medial fibers of gastroc and soleus. So think about how you can really sort of customize. And another thing I just wanted to touch on quickly is if you're noticing that within a muscle itself, you need more focus on the proximal or the distal fibers, you can adjust the joint angle to really customize, put more focus on the proximal or distal fibers as opposed to mid belly of the muscle. So if a joint angle is typically in a more open position, you're going to be targeting more of the proximal fibers. So that's why understanding your origins and insertion is helpful. And then in a more closed joint angle, you're going to target more of the distal fibers. So that's something to think about and play around with when you're even just palpating, pick a muscle, palpate the proximal distal ends, try adjusting the joint angle and see if that helps you to customize. And if you're not seeing results, try something different, try a new path, try again, going back to these vectors and lines and patterns and, what are you trying to build robustness in? So I hope this was informative. I hope that you were able to gain a greater understanding of, your core stabilizers in terms of their anatomy and their functions. And I really wanted to sort of tie that into, how that applies to movement and how we can sort of, bring this into our lives as movement professionals. So bring that understanding into, into our day-to-day work on ourselves and on our with our clients as well. So, okay, I think I see some questions in the chat. So you sound great even when you leave the desk. Okay, thank you. Would one QL be tighter than the other if you're carrying a child with a hip drop? Possibly. I mean, I prefer, I would want to test it to, see what's tight. But yeah, absolutely. We could certainly see one QL tighter if the hip is hiked and if you're in a bit of lateral flexion. So that can certainly cause some QL tightness. And we see this all the time. Carrying a child, even in day-to-day work situations. What do you call this exercise? I use this for piriformis syndrome. Oh, darn. What was that? What exercise?
It was the one where you had the ball against the wall and you were applying.
Okay. So I don't know if this is what other people call it, but we call it a ball wall hip abduction. Okay. So I really would love for you, you're all going to get the recording of this. So I would love for you guys to go back and actually try the exercises and see if you can feel the connections. And so, yes, we call it a ball wall hip abduction. Glute max, all good, keep learning out. Did I make a mistake? Did I refer to glute med or glute min instead? I may have, sorry. It's late, I'm tired. All day. I'm sorry if I mistook one exercise. The core engages before the limbs. Yes, that's the anticipatory roll. Therefore, the low back will fire before the glutes and the hamstrings, right? Okay, so that's interesting. Yes, in terms of the multifidus, okay, so the multifidus as core stabilizers is going to contract. But if we're thinking about pure hip extension, yes, we want some core contraction to stabilize the whole lumbopelvic region. But as soon as we're moving the leg, we should see the glutes fire on hip extension. Now, sometimes we get a lot of extra tone in the erectors, in the lumbar, the erector spinae group. And that's what we're really concerned about, an over dominance of that area. So we don't want to have an over dominating effect of the lumbar erectors in hip extension. We don't want lumbar extension, we want hip extension. So certainly the multifidus will fire because they are anticipatory and core stabilizing, yes. Would you be able to provide more info on those manual muscle tests? So I did speak with CSEP, and we do plan, I hope, when we can meet in person, I hope to be able to offer a workshop on manual muscle testing, because it's been a game changer for me and a lot of other practitioners that I know. So, but if you're interested right now, neurokinetic therapy, and then any sort of information on muscle testing. I know there's a lot of other programs that teach manual muscle testing. Have you come across any information about chronic levator scapular syndrome, where levator scap is dominant compared to upper trap? So yes, I think it depends. I see a lot of dominance in levator scap and upper trap. It depends, but we treat what we find. So if we're finding that the levator scap is dominant, then that's what we're going to be releasing and stretching, which is going to be different from an upper trap release. So yes, that's very, very common. Thank you. This was a helpful refresher. Amazing. You mentioned plantar fasciitis being tied to a weak glute. Can you elaborate more on a strategy to help clients? Yes. So watch your clients in gait mechanics. If you're seeing an over dominance of the calf muscles and not a lot of glute recruitment, or even just in like a hip extension movement, if I see my clients pointing their toes and tensing up their calves, I don't have to use a manual muscle testing system to know. I can just visually see that the calves are super dominant. So what you can do to help: release, just like any compensation, release the overworking area. So release the gastroc and soleus, because they insert into the Achilles tendon, which inserts onto the calcaneus, okay, under the heel of the foot. Release the calf and the soleus and gastroc, roll and stretch, then do a low level glute activation, and then do your integrated glute work. So see if that helps with your plantar fasciitis. I was only able to get to the link to the seminar after 7 p.m. Pretty frustrating. Okay, yes, you will all be sent a replay of this, so you'll be able to access it and watch the replay on your own. Thanks so much. I'm sorry I was late. Okay, great. Thank you. I agree with Danielle. Very helpful refresher. Thank you. My pleasure. This is great. I'm so glad this was helpful. I didn't lose anybody. It wasn't boring, and just anatomy can be so dry. Terrific. Thanks for being so animated. That's me in my face. Thank you. A great refresher. Are you going to email us? Okay, I'm sure I'll leave that to CSEP. I'm sure they will. Thank you. Enjoy. Thank you. Okay, awesome. Oh, great. Amazing. Oh, when you showed that exercise for the psoas with the leg lifted and abducted out slightly, should you really be trying a posterior pelvic tilt and really pressing the small of the back into the ground? So a slight posterior pelvic tilt can be very effective. I'm not really a huge fan of pushing the low back into the ground. And I know this is old school. I know we were cueing this like 10, 15, 20 years ago. But I'm really a big fan of maintaining neutral lumbar alignment and focusing on core stability anteriorly to help with stabilizing the lumbopelvic region. So if you're excessively in an anterior pelvic tilt, sure, a slight posterior pelvic tilt could be helpful. I more look at the rib hip alignment. So making sure that the ribs and hips are lined up before, proceeding with any sort of supine exercises. What city are you in? I am in Ottawa. I am the co-owner of Continuum Fitness in Westboro. So feel free to reach out if you'd like to connect. Thank you for this informative. Great to, okay, yeah. Definitely review, because I think that will be helpful, because it's a lot of information. Looking forward to rewatching. We'll see this part 2. Fantastic. Thank you. Oh my gosh, this is great. I really appreciate all of these notes. I don't know that we have any questions, any more questions at this point, but I will, let me just stop the screen sharing here. Sorry. Yeah, I will hang out here if you guys have any other questions. And thank you so much for being interested in anatomy. And I hope that it was helpful. And I appreciate all of your comments and feedback. And watch the replay and let us know if you have any questions. I hope so. I am offering a couple of other sessions. So there on March 30th, there is going to be return to run post injury, which is going to be a really great session if you work with runners, especially runners who are injured, who maybe have finished with their physiotherapy and not quite ready to jump into a 5K. And then in April, we're going to be doing post-rehab next steps. So I'm going to elaborate on a lot of these exercises in terms of, okay, you've got someone doing a clamshell, but how do you get them to like a standing exercise? So post-rehab next step is going to help with bridging the gap from rehab to fully returning to activity. So those are a couple of the other workshops we have coming up in March and April. And thank you so much, everybody. Have a wonderful evening. Oh, do you plan on offering the postpartum session that was originally? That was an error. I'm not sure what happened. I did offer that as a session, but because the new pre and postnatal specialist program is out, I think they're going to spend some time focusing on that. But maybe in the future, postpartum is really my jam. I really love that. So I hope to be able to offer some sessions on pre and postpartum programming. So maybe if you wanted to, submit your feedback to CSEP and let them know what you'd like to see, maybe that would help drive some things. Are there any other courses that you have taken that would be helpful in your career? Neurokinetic therapy, level 1, 2, and 3 has been great if you're someone who's really interested in compensatory compensations and manual muscle testing. Reconditioning level 1 and 2, really big fans of Scott and Jamie Livingston. And then there's people that I follow, Kathy Dooley, her immaculate dissection programs are really key. Yeah, I think that's a great start. That's a great start. So yes, if you have any further questions, please send them to memberships@csep.ca and Sarah Moore can help direct them to me. So thank you, everyone. And I hope you have a wonderful evening. And we hope to see you at a future workshop soon.